Hey, junior class, this is Dr. Aang coming with you to give you a highlight of neonatal abstinence syndrome. We're going to kind of capture what that is by defining neonatal abstinence syndrome. We're going to look for some of the signs and symptoms that we want to be aware of during the newborn assessment, as well as looking at some of the interventions. How are we going to scale that to determine our plan of care moving forward to reach optimal outcomes for that newborn that is experiencing neonatal abstinence syndrome. For cases of this highlighting clip, which will be relatively short, we're only covering this one topic. However, during this video, I'm going to refer to neonatal abstinence syndrome as NAS moving forward here. So what is it? What is NAS? Basically, the mom is supplying, as we know, any nutrients, any substances flowing through that mom's body are going to travel through the placenta, then in utero go right to that fetus or to that baby is how I'm going to reference it moving forward. But that baby is going to receive any substance, be that good, be that harmful. Those substances are reaching that baby through the placenta. Then once that cord is cut abruptly, we are going to have a significant disturbance to that newborn because that substance is now cut off. We're going to reference that as cold turkey, but cut off. It's not weaned off, but there's an abrupt stop to that substance that that infant or that newborn has been accustomed to inside the mom, receiving that from the placenta. So this is similar to how it would be for an adult or for anyone else. If you have that substance, it's abruptly cut off, there's going to be some significant disturbances to the homeostasis of that child, of that newborn. So obviously the abrupt withdrawal is the concern. So what are we going to look like? What does this look like when you're doing your newborn assessment? For about 6 years, I was a newborn nursery nurse. This was before it was kind of the room-in philosophy. But regardless, as the newborn nurse, you're going to take that baby, you're going to do a thorough assessment. And what are some of these things that you're going to look for? Any one of the symptoms standing independently may not be indicative of NAS. However, when they're coupled together or they're on a scale, obviously, from less severe to we can move to the other side where they can be life-threatening. So where they are on the scale of severity and then coupled together with other signs and symptoms. On this scale, as we learn how to scale this for NAS, is going to be obviously driving the train for what the interventions will be moving forward. So hyperthermic, the newborn is going to be febrile, typically around 104, which is 37.8 Celsius. That's going to be the range of feverish. This can look, they can look clammy, they can look sweaty. This also can be masked because the newborn is going to be crying. They can be crying to inconsolable, to the point of, which is a cardinal sign and more severe, is a high-pitched screaming cry that cannot be consoled. That is a kind of cardinal sign of NAS. So again, very distinguished high-pitched cry. They're going to be tachypnic. Respiratory rates can climb up, obviously, out of abnormal into abnormal levels, around in the 70s and 80s. You can see above 80 even. So tachypnic. Then persistent watery diarrhea. And you think about they're trying to pass the meconium. Typically that's what we're focused on, but this child's going to look very much different. The newborn that has a persistent watery diarrhea, and again it's persistent, continues on. So what does that do? If anything is persistent, especially in the case of diarrhea for a newborn, we're going to be concerned for skin integrity. The integumentary system is going to be at risk here. So changing diapers frequently when they're soiled, when they're wet, getting that off the skin. You might even apply a cream, a barrier cream, in order to help with that. You can see the baby, the newborn, anywhere from sneezing to severe respiratory distress as well. They are not good feeders. They have difficulty feeding and grasping that feeding suck swallow pattern and getting a successful latch, be that breast or bottle. They will have significant concerns with feeding. However, the newborn with NAS is going to have a suck pattern that you're going to see in non-nutritive situations. So even when they're not trying to feed, they will have a sucking rhythm. So you will note that as well. They are often hypertonic. So you'll notice when you're trying to do these diaper changes, they're very rigid, which makes it difficult to do a full assessment. Changing diapers, things of that nature, you'll notice that hypertonicity and rigid behaviors for that newborn. So these are all a few of the cardinal signs and symptoms, and as you'll notice, one on its own, you may get a newborn that's inconsolable and crying. That could lead to maybe even like lactose intolerant. There could be other things going on. However, when that is coupled with, let's say, the high-pitched crying, and you're moving over and you notice, okay, this newborn is also tachypnic. Now I checked and they have a fever. As these start to compile, it's going to be indicative of NAS, and we're going to want to look for that. Sometimes we have maternal history, sometimes we do not. So we need to be able to pick up NAS during a thorough newborn assessment, whether we have that maternal key piece of information or not. So there is a scale, an NAS scale. The lower the score, the less severe. The higher the score, the more severe. And that will, again, drive the bus for interventions for the newborn with NAS. So if we have a couple scores that are ranking around the 2s and the 3s, that's going to be non-pharmacological interventions that will be in play, such as we're going to want to swaddle this newborn very, very tightly. We're going to swaddle them tightly for that comfort and consolability of that. However, we are going to cluster care to give them time that is non-stimulating. So where is the case of a normal newborn, we're wanting to hold the newborn, grandma's there, wants to rock the newborn, we're passing the newborn around, and everyone is getting their time of stimulating that newborn. That is not the case for the newborn with NAS. We're going to want to have non-stimulating times and clustering our care. Keeping in mind this is tricky because we're also wanting to do frequent diaper changes because of that persistent diarrhea that will be indicative of NAS as well. It's one of the significant cardinal signs. So not having a TV blaring, not having music, not touching and stimulating any more than possible. Another thing I wanted to note with this, the newborn with NAS, if you walk up to the infant, this is actually a reflex that then will go away typically, but there's that startle reflex. However, if the newborn startles and they're not even being disrupted by a caregiver, and you just notice them startle, that's more of a severe sign as well. But then we look at if they're scooting up to on the NAS scale, if they're receiving more, 8s to 10s, and sure, if they hit up to a 12, we're going to need to implement moving beyond the non-pharmacological interventions, and now we're going to need to implement something. So we're going to look at first, if it's severe, the severity is on this end of the scale. they may need a bridge dose of morphine in order to help stair step them down off. It's going to be more than just a slight wean. If we're coming down eights, coming down on the scale a little, they can come in with methadone, and we're going to wean those doses as much as we can to get that newborn weaned off of the substance, whatever the substance was. We need to wean them off of that in a safe way so it's not that abrupt discontinuation of that substance. And again, things that we look at, this can be oxycodone, it can be a prescription, it can be even a substance abuse that the mom is being treated for. Trying to think, it can be illicit drugs such as heroin or cocaine. If they did have a prescription for oxycodone, that would come into play as well. If they were in recovery, they may be the maternal influence may have had methadone, Suboxone, anything that is a substance that newborn was used to getting in utero. It's abruptly cut off. We just have to help wean and bridge that back to help support optimal outcomes for that child. So let me see if we missed anything here. Again, be familiar with scaling, looking at the scale and being able to see, are they a 1 or 2, 3? Is it up on the severity to a 12? And what would those interventions look like based off of that assessment that you have done? I want to give you a little practice NCLEX question. So say you have a newborn that comes to you during your assessment and they are withdrawing from heroin. Select all that apply that you would think would be indicative of a newborn that is withdrawing from heroin. So A would be a temp of 36.5 or 98.1. B would be a respiratory rate of 88. C would be they are diaphoretic, and then D would be constipation. So select all that apply to a newborn diagnosed with NAS or coming off of heroin, withdrawing from heroin. The correct answers would be B and C, respiratory rate of 88 and the diaphoresis. Severe respiratory rate of 88, and these are signs that we would expect from a newborn during an assessment that is withdrawing from heroin or experiencing neonatal abstinence syndrome. So the diaphoresis or excess sweating, it's very common. They're irritable on top of this, crying, very hot, sweaty, clammy. And then incorrect answers. Hopefully you didn't pick these, but a temp of 98.1 would be normal. We're expecting that they're going to be febrile, so we're going to look for a abnormal temperature for this child. And then constipation is complete opposite of that of a newborn experiencing NAS, because they are going to have that persistent watery diarrhea. And what are we checking for this? We're monitoring their skin integrity to make sure we don't have that skin breakdown. Again, although we're trying to be non-stimulating, we do want to get those diapers off as quickly as possible. So when we're clustering care, making sure that assessment of that skin is going to be paramount when we do cluster that care, and offering that barrier cream if possible. So know that we may or may not have maternal information, and we still need to be able to pick up signs and symptoms of NAS. Know the signs, know how the scale works, and what would be the less severe and non-pharmacology based interventions. And then on the other of more severe, if the severity increases up to a 12, we're going to be implementing our pharmacological interventions, such as most severe, needing a bridge. You may have a dose or two of morphine, low doses. whereas then the methadone is going to come into play in order to stare and wean them back down off of that substance. So if you have any questions or concerns related to NAS, I am more than happy to help with those. Otherwise, if you are familiar with this, you will be good to go for these questions. Take care.